while it's again, it can decrease the volume of prostate cancer, and this will may succeed to let you increase the dose to the volume of the radiation. The 10-year cure rate for patients with the high-risk prostate cancer is just similar between the similar radical prostatectomy and the radiation therapy with the hormonal treatment at a 10-year survival rate of 92% in each of these. While if you use radiation alone, it is a little bit lower, but it's not significant again, with the 88% 10-year survival. The long-term functional outcome after treatment for localized prostate cancer side effects, we have the urinary incontinence is worse with surgery at the 2 and 5 years, but when we comes to the 15 years, it is equalized both the surgery as with and the radiotherapy. The erectile dysfunction is much worse with surgery at 2 again and 5 years, while it is equalized again at the 15 years point. The bowel urgency is worse with radiation at the 2 and 5 years, but when we go to the point of 15 years, it is again is the same. More importantly, that we can use Viagra to enhance erection, and this is successful in surgery in 43%, while after radiation it is successful in 70 to 90%. Remind you that the usage of Viagra or Cialis in the general population is within the 80% success. For the integrated conformal radiotherapy process, we have to go through these 6 steps. First of all, the immobilization and repositioning device, and this is very important, followed by the volumetric data acquisition, and this is done either by either the CT scan or nowadays it can be done by the MRI simulator. However, we can still do a fusion between the MRI and the CT simulator in order to get to a more accurate delineation of the volumes. After that, we have to do the virtual simulation and delineation, and the dose distribution and calculation is mainly done by the TPS, the treatment planning system. And then we have to do the acquisitions of the treatment through the linear accelerator or the other device. And then the most important, and much of this talk will be about the treatment verification of this treatment. So this is the immobilization, and there is a lot either by a thermoplastic device, thermoplastic sheets, or by the vacuum mattress. This is a CT simulator, and this is the MR simulator. The MR simulator is coming very strongly. It has one obstacle that we have to calculate the isotopes through the Housefield number or the CT number, and so we have to have there is some way to change the pictures of the MRI into this number, and so you can use it with the TPS. This is another, again, you have to have a mobile coils in order to have a good, with a flat table and a wide ore for the MRI, again, in order to have an MRI, a good MRI simulator. This is the delineation, and my colleague Dr. Ahmed Abdullah will talk about this. We have to delineate the prostate, the seminal vesicle, and the Nile valve, as well as the organ at risk, the bladder, rectum, head of femurs, and all these cells. This is the, as you can see here, there is CTV and GTV, and both are the same volume. So this is a unique for the prostate cancer. Otherwise, if you have a choline PET scan, so you can identify the volume that is affected in the prostate, and through this you can increase the dose more than the other part of the prostate. I have to remind you that the CT gives you a 32% larger volume than the prostate. And this is why it's better to have an MRI delineation either by fusion or by MRI SEM in order to be more localized. It comes mainly from the capsule of the prostate, which can be seen quite well in the MRI. Another good thing to see in the MRI is the penile valve, and this is very important because the impotence is affected much by the dose to the penile valve. This is the delineation again. So, can we do it with 2D, or we have to use the 3D? Actually, the 2D, you cannot increase the dose to the good level. So it is not good to use the 2D for the prostate cancer. The 3D, the three-dimensional, is good to have, but it's still you have to have the IMRT. This is the 3D conformal. The dose, I don't think that you can have a dose more than 72 with the conformal radiotherapy, but with the IMRT you can have up to 80 gray, and we are doing this 80 gray very safely and without much side effects in our department. This is the IMRT, and the IMRT, you know that you will have the distribution, you will have the DVH, and you have the DVH for the BTV, as well as the organ at risk, and so you will get those statistics for your plan. You get everything with its dose. By this you can get the mean, but now the mean is not the only thing to look at, but here this is the quantic. You have to see how much of the volume receive how much of the dose, and this will determine your choice of the plan. And this, if you go to the with these rules, you will expect much less side effects for the mainly for the rectum or the bowel or the bladder, and this is of course, and also the benign valve, and left with the head of femurs, and this will get a safe distribution of the plan. Now we will come to the treatment verification. The treatment verification, as I just mentioned, you have to have IGRT with each day of IMRT. So there is a significant movement of the prostate gland based on the daily gas in the rectum. So you will not be able to control the gases in the rectum. So you have to control the treatment volume according to the whatever you have in the patient at the time of radiation. And as you can see here, this is the gas. This is the plan, and this is the of today. You get the most of the PTV and the rectal rather than.